Appendicectomy. Types and procedures. The appendix is a small sac that hangs from the large intestine. Location: sits at the junction of the small intestine and large intestine, and normally, the appendix sits in the lower right abdomen. The causes are: increase of lymphatic tissues due to viral or bacterial infection and obstruction due to tumors, fecally or intestinal worms. Common symptoms: abdominal pain, loss of appetite, low fever, nausea and vomiting, diarrhea or constipation. Complications can be peritonitis and abscess. Appendicectomy. An appendicectomy is a common emergency surgery where the appendix is removed when it becomes infected. Open appendectomy. It is the traditional operation for appendicitis. It requires a medium-sized incision to be made in the lower right part of the abdomen. Surgical technique. After preparing the skin and the field, a MC Burney incision is made. Dissection of the anterior fascia, minor oblique muscle, anterior rectus muscle, posterior fascia, and incision of peritoneum with Metzenbaum scissors and hemostasis with electric scalpel. Location of the cecum by following one of the tapeworms until reaching the base of the appendix. Extract the appendix taking the distal end of its mesoappendix with Peacock forceps and Metzenbaum scissors and gauze. Cut the mesoappendix inside the pedicle artery, releasing the appendix with hemostasis forceps. Once the appendix is released, making a bag of tobacco or purse at its base. Begin the septic time by ligating the base and cutting the appendix with a scalpel. The stump is invaded with a forceps appendicular. The appendix and the contaminated material are delivered. Subsequently, the cavity is washed and reviewed, gauze and compresses count and closure by planes. Laparoscopic appendicectomy. It is a surgical technique that is easy to perform, safe and with advantages over the open technique, since it has less morbidity by practically avoiding wound complications and having higher diagnostic accuracy. Surgical technique. The procedure is performed with the patient under general anesthesia. The surgeon and the assistant stand to the left, the monitor to the right side and the instrument to the feet of the patient. The surgical field is prepared with povidone iodine. An incision was made in the left lateral region of the umbilicus of approximately 2.5 centimeters. It was deepened to the linea alba. By puncture with a disposable Verus needle, the pneumoperitoneum was performed at 15 mm of mercury, 2 conventional disposable trocars of 5 mm and another of 10 mm were introduced, placed along the incision to access the abdominal cavity. With the rigid 5 mm lens inserted through the superior trocar, a diagnostic laparoscopy was performed, which confirmed the inflamed appendix with surrounding fibrin and partially adhered to the parietal peritoneum. An intraumatic intestinal forceps is used to pull it, which facilitated the dissection and section of the mesoappendix. The harmonic scalpel was used for this. The appendicular base, after ligation with tubercle endoloops, was sectioned with the harmonic scalpel. Finally, the appendix was extracted using a 10 mm extraction bag through the corresponding trocar. The umbilical aponeurosis was sutured with the gall in the skin with metal staples. Thank you very much for your attention.